advocacy, and clinical work, looking at the effects of prenatal and early life factors in childhood obesity and the earliest, most impactful interventions for prevention. We have Dr. Janet Wojcicki, a researcher and assistant professor at UCSF and member of UCSF's Center for Obesity Assessment, Study, and Treatment. Julie Matthews, founder and president of Nourishing Hope, Food and Nutrition for Autism, ADHD, and Healthy Children. And Naomi Stoutland, a physician and associate professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at UCSF. She's also a member of UCSF's Center for Obesity Assessment, Study, and Treatment. So my first question is for Dr. Wojcicki, and that is, what role does maternal weight seem to play in childhood obesity risk, but also childhood undernutrition?
First of all, just in regards to your definition, I think we should think about maternal overweight, obesity, actually all overweight and obesity as a type of undernutrition, because oftentimes we see micronutrient deficiencies that are associated with obesity and overweight, anemia, calcium, a variety of different deficiencies. So I think it's kind of a misnomer. People often think, oh, they're overfed, they have too much, but they're actually, it's a form of malnutrition, undernutrition as well. In terms of how maternal overweight and obesity can impact risk for child obesity and overweight, there's a variety of different factors that play in. But I do think, this panel is entitled Pre and Postnatal Health, that in terms of prevention, we know how difficult it is for kids to lose weight once they are already overweight or obese. So in terms of prevention, I think the earlier the better. Prenatally, in the postnatal environment, those are the time points really kind of to step in and do something. We know that there are genetic factors, so if mom's overweight or obese, there's a risk that the child will be as well, but there definitely are modifiable environmental factors that play in as well. So we know if mom is overweight, obese in pregnancy, there's increased risk for the child being either born too large, macrosomic, high birth weight, or low birth weight. And both ends of the spectrum are associated with increased risk for childhood obesity because of metabolic perturbations in pregnancy. Moms that are also obese or overweight are less likely to breastfeed their infants for hormonal, physiological reasons. They're also more likely to have, and I know that Naomi is going to be touching on this, C-sections, which disrupt the microbiome of the infant, again placing the infant at risk for future obesity. So there's a variety of different mechanisms at play being responsible for the pathway of development between maternal obesity and later childhood obesity. A lot of environmental ones. See if there's anything else that I wanted to touch on. There's also, I guess, you could look at the fact that if mom is obese, this is more postnatal, the environment that the childhood is going to be exposed to. In terms of the food environment, what the mom is eating, she's going to subsequently probably feed her child similar types of food. But we just heard in the last speaker about, the home food environment, cooking, access to processed foods. So very important. It's not just the child's feeding environment; it's the family's feeding environment. So you want to kind of think of it as a unit in terms of what's happening and what's going on.
Dr. Stoutland, has the number of women you see with gestational diabetes gone up, and what risk does that pose for childhood obesity?
Yeah, I thought about this question. I don't have data from my patient population about the trends in the 15 years I've been practicing. It was high when I started as a percentage. My patient population at San Francisco General is predominantly Latina immigrant patients that we know that they have a very high risk of both gestational diabetes and type 2 diabetes. So I don't know that I would say it's been going up. What I feel anecdotally I've seen in that patient population is that the diabetes and the chronic disease in the young women I care for has gotten worse and more severe. So I feel like I more often see women with really severe diabetes, poorly controlled, with hypertension, severe hypertension in their early 20s. So these are metabolic syndromes that I believe, again, are pre-programmed in utero, potentially from when they were in the womb as babies. So I can't say whether in the last 10, 15 years the rates have gone up, but I feel like the disease has gotten worse.
And a quick follow-up to that, what have you found to be the best educational resources for women with gestational diabetes?
Well, I was just going to say, I'd love to hear about the Coursera course about cooking for children at home. And I think it's been a struggle because, again, my patients are largely Spanish-speaking, monolingual Spanish-speaking, and there aren't a lot of great resources that I've found for them in terms of teaching them how to eat better. We're very lucky at San Francisco General Hospital. We have dietitians on staff who do a wonderful job counseling our patients, but they still face issues like food insecurity and access to healthy foods. And one of the things that I'm very excited about at San Francisco General Hospital is that there's been a team of doctors and other healthcare professionals who have lobbied and raised money to open a therapeutic food pantry at San Francisco General Hospital. So I'm really excited that that's coming in the future. They're actually going to target two specific populations in their pilot project. One is women with gestational diabetes, and the other is pediatric obesity. So it's basically going to be, clinicians are going to provide a prescription for their patients to get healthy foods from the food pantry. So that's still a work in progress, but it does look like it is going to happen. So that's going to be a really key resource for our patients.
Wow, that's really exciting. This is a question for everyone. What are the benefits of breastfeeding for childhood obesity prevention, and what are the biggest barriers women face to breastfeeding more?
Maybe I'll just take this to start. So I'm Julie Matthews. I'm actually a certified nutrition consultant as well. I work a lot with pregnant women and kids. So, in part there's a lot of research showing that breastfeeding babies decreases the potential risk of them having obesity, and there's probably a number of reasons for that. Breast milk is the most dense nutrition that they can get, and they feed on demand and they stop when they're done. They don't finish the bottle and things like that. So that just sets them up for a life of when they need nutrients, they get them, and then when they're done, they stop. And so they have more of that natural mechanism themselves. And there's also some research showing that formula feeding can increase the insulin levels and things, which could also have a potential effect on children as they continue to grow and develop. I would say that those are a few of them. And for me, in terms of what are some of the barriers, I think it's education. I think it's partly understanding the importance of breastfeeding and the value of the additional nutritional value for them of doing that. And I think that, to me, that's the thing that people, I think, are lacking the most, is the education on why they should do it. And why they should take that time, as Dr. Adam was talking about, to make all that food and do all of that. So to me, that's probably the biggest barrier.
Can I
add anything?
Yeah, and there's so many barriers to breastfeeding in this country. One of them is working, and women who aren't granted maternity leaves of any length or no length, and have jobs where they're not encouraged or they're actively discouraged from pumping their breast milk. So that's a huge one. There are also big cultural barriers to either breastfeeding at all or exclusive breastfeeding, which we know is the healthiest for babies in the first 6 months of life. And I have most experience with our Latina population, and there have been some wonderful researchers in California who've looked at some of the barriers in that population, exclusive breastfeeding, and things like even just living in an apartment with where people hear the baby crying a lot, it disturbs the neighbors, and so they give the baby a bottle at night to keep the baby quiet, and learning cues. The education part is huge in terms of that, and understanding the cues from the baby about, does the baby really need more food, or does the baby need to be comforted in a different way? And that just having our patients understand that the babies actually almost always are getting enough food from the milk. There's a huge cultural belief often in these populations that the baby's not getting enough food, that there's not enough milk, I don't have enough milk. So there's a lot of education that needs to go on there.
Yeah, I just want to follow up on some of your comments in the sense that we really don't have institutional or environmental structural support for breastfeeding. If you look around in terms of breastfeeding rooms, spaces that mothers can go to breastfeed. It's rare. It's the rare employer that offers those perks where they should really be standard of course and in all public places. So I think that as a society, unfortunately, we don't support it. And the maternity and paternity leave are both necessary. And again, we don't really offer that. Employers, culturally, we don't think that it's necessary that whole first year of life. But if we are committed to having healthy kids and having this prevention, then we really need to change our perspective on the importance of early childhood, early life factors, breastfeeding.
This question is for Julie. What nutritional advice would you give for a young child after breastfeeding to set them up for a healthy metabolism?
I think it's introducing them to good food as early as possible, and a lot of different flavors of food as well. To even take it a step back further, breastfeeding moms can do a lot even then before they start weaning, because actually babies can taste different flavors in the milk, whereas formula-fed babies are just all the same. So they really can get a great head start in terms of all sorts of other little intricacies of flavor that might set them up to be a little bit more of an adventurous eater. And then once they are starting to eat, I mean, to me it's obvious, but like not feeding them sugar, and you might be surprised at how many I see, like little kids going around with soda cans and things like that. Really shocking to me. Being really careful. And I would say fruit juice to me is the same thing. Like water is good. I would avoid any sugar drinks. Those are probably one of the biggest ways to add that sort of set them up for a metabolic issue or diabetic or some sort of blood sugar issue later. So to me, that's one. Looking at obviously getting good nutrition, getting good, I'd love to get sour foods or bitter foods, or work on one of my favorite foods for my daughter when she was about 10 months and she had some teeth, was sauerkraut. It's really sour, and I wanted her to get used to the sour flavor and get the good probiotics in it, and to this day she loves it. And so I think really just encouraging kids, they don't have to eat kids' foods, and encouraging families that just eat the kind of food that they're eating and make it healthy. This one's a little tougher for kids because kids tend to be a bit of grazers anyway, but we know that people that graze like adults that graze too much, that can really be problematic for leptin and ghrelin levels and appetite and different things like that. And so with kids, they do kind of a little bit. They eat small meals frequently. But I would say when we're talking about grazing, like drinking apple juice all day long, that kind of thing for little kids, or just eating, like filling in the gaps with cookies or crackers all the time. There's probably some benefit to all of us having kind of where we eat and when we digest, that allows the migrating motor complexes and all the digestive capacity and all those things to do its job, and blood sugar and appetite and all those good things. So I think just eating healthy food and avoiding the trap of getting into sugar too early is probably one of the biggest things.
Dr. Stotland, do C-sections play a role in childhood obesity risk? And if so, what can be done to educate physicians and patients more about this?
Yeah, so this has come up a few times during the day at this meeting, and in the morning panel, there was discussion about the way we do know now that babies get their gut flora from being born. I mean, that's the main way they get their healthy gut flora. Obviously, babies who are born by C-section without labor get a gut flora somehow, but they get it more from exposure after birth, through touching mom's skin, through the hospital. So it's been shown now clearly that babies who are born, and I wanted to make one point of clarification from what the morning panelists said. There seems to be, the babies who get the most abnormal gut flora are the babies who are born by C-section without any labor. So the women who, it's a little bit of a nice thing to hear for the women who go through like 3 days of labor with ruptured membranes and labor and then end up with a C-section, they actually do get some of the benefit, because when the cervix is dilating and the bag of water has broken, and those vaginal flora and the gut flora from the mom do migrate up to the baby somewhat. But when you have a C-section boom without any labor starting, those are the babies who really don't get exposed to the bacteria that, and when they've actually shown this in studies, that the babies who are most affected are the ones who have the C-section, the planned C-section without labor. And so now the and as the morning panelist said, they have seen an association between delivery by C-section and obesity, but it's not proven causation. So I think a lot more research needs to be done into this, but there is concern, and certainly I, as a parent, would not want to have a situation where my baby has abnormal gut flora for a lot of other reasons, and C-section has also been associated with allergy and asthma and things like that. So I think it's too soon to say for sure that C-section is playing a role in the obesity epidemic. There's a lot of reasons we could see the association the other direction too, or the causation. So babies that are already big at birth are more likely to require a C-section because they're big babies. So I think there's a lot of complicating factors here. But what I do want to say is what we already know in our field is how to reduce the C-section rate. And so there's a lot of efforts going on, but we need to do even more. But we know there are a lot of things. And one of the things I like to say, to my patients in my clinic, just because you are obese does not mean you're going to get a C-section. And I think that's one of the problems in our field is that, the doctors see a woman with a high BMI and go, oh, she's going to need a C-section, and they're more likely to do a C-section potentially at a lower threshold. So I think women who start pregnancy obese need to have more advocacy for them to still support normal physiologic birth.
Julie, there's a much higher rate of obesity among children with mental health issues, such as autism. Why do you think this is?
Okay, so by the way, I want to add, it just dawned on me, there's one other thing for just general kids, and that's actually MSG. MSG actually is, it stimulates the glutamate receptor and it causes us to eat more foods, and also can damage the hypothalamus and affect appetite. So just adding to the no junk food would be, to me, that additive is to add on to it. So the reason I guess I'm answering this question on autism is because this is actually what I've specialized in for 14 years and done a lot of research on, both in university level as well as just lots and lots of my own personal research on the subject. And I think there's a lot of things. We don't know everything. We don't know we don't know what causes autism. I don't think we're ever going to find a single cause or quote single cure. So all I'm looking at it from is a biochemical perspective and what we think might be going on. And the research does show that children with autism do have higher rates of obesity. And about 50% of them, it was not due to an issue with activity level. They did find that they ate about, in the second study, they showed that they did eat about the same amount of calories. And that there was also but while those calories were different in that they had more carbohydrates and less fat. So while the calories were the same, just the mere fact that they ate more carbohydrates and less fat could play some role in maybe higher insulin levels or some factor of storing more weight rather than burning it. So there does appear to be something going on with that. I pondered this for a while actually, and I have some ideas. Again, they're all just sort of biochemical thoughts and theories on things. But there's a few things. One is the microbiome. We know that children with autism have a very different microbiome. We know that they have some strains of pathogenic bacteria that other people don't have. They have less beneficial good bacteria, and that this beneficial bacteria is really important for regulating our body, the amount of fat we store, and all sorts of things related to obesity. So I think the microbiome would be a really interesting one to look at. Again, the thing about autism is that I don't think that we're going to find one type of autism. The more and more I look at this, the more I see that some have gut issues, and some have immune issues, and some have mitochondrial issues. And so if we take those and we break those up, I think that's why we don't find the causes and associations as much. If we break that up, we look at, okay, there's a percentage of them that have mitochondrial issues. Well, mitochondrial issues themselves can have effects on burning calories and burning energy, and so that could be a factor for some. There's the microbiome issue for another. There's immune system dysregulation and inflammation is a big factor behind most mental health disorders and obesity. And we know that children with autism tend, in a study that was actually done by Vargas, showing that they have brain and systemic inflammation more than the average person. So there might be something there that plays a role. And they also have more likely chance that they're going to create opiates or opioid-like compounds from the food that they eat. And as Dr. Adams talked about gluten, we look at gluten and dairy and stuff, these children actually have high rates of opiates in their urine. And one thing that opiates can do is cause us to crave sugar and these kinds of things. So again, I don't think we have the answer. I'm not saying I have the answer, but I think that one thing I do feel very strongly about is that autism is not just a sort of brain condition where it's just this isolated silo of, a psychological or psychiatric problem, but it's a medical condition. It's a whole body condition. It's a physiological and biochemical condition that affects the brain, but also affects the whole body. So how can we just support areas we can support them, whether it's they get a little bit better, they do better, they have a better weight, they're healthier in general, they're not suffering from GI problems as much, whatever that is for that individual. So I'm always looking at what's going on biochemically and how we can support those individuals, rather than coming up with some global statement that this causes autism and everybody needs this, because I haven't found that in my 14 years of working with families. So.
And how do you work with parents who have a mental disability, and maybe not even a mental disability, but anything from a behavioral issue to a mental disability around nutrition?
Right. Well, we need to get the good nutrition in, because they need the good nutrition as much or more than everybody. And what I found we do know that kids with autism actually have sensory integration, challenges around food, sensory aversion, or food aversions, and in some cases those are sensory related, anxiety and other types of related things. So what I do a lot is work with families in terms of making the food nutritious and fit in with their texture issues. A lot of times they don't like slimy things, or they don't like like mashed potatoes with lumpy things in it or something like that. So I'm always looking at how can we make food good? How can we make French fries out of carrots or parsnips or rutabagas? How can we make chips or crunchy things or kale chips? So how can we make vegetables not only taste good for kids, but have that texture that they might really enjoy more? So I do a lot of things around that. Or if kids don't like sour foods and they don't like sauerkraut, I make something called apple kraut, where I grate apple in and I take the sourness away, but they still have the good probiotics. So I'm always looking really at making things kid-friendly, is really.
Oh, sorry, yeah. I just wanted to also add in that I think it's important to consider when we look at risk factors for obesity that mothers that have any type of mental health issue, that can be a risk factor for the child's obesity. So in the area that I do research, I have 2 longitudinal cohorts, mothers that were recruited in pregnancy, San Francisco General Hospital, exclusively Latino families. And in these families, the moms that had any type of perinatal depression, prenatal, postnatal, were more likely, they were just at greater risk, I think because they have fewer emotional resources. They were at greater risk for not following American Academy of Pediatrics recommendations for introduction of complementary feeding. So they were feeding their kids as early as 4 to 6 weeks of age, sugar water, sodas, other juices that are clearly not recommended for infants of that age. We hypothesized in part because they just have fewer emotional resources. When you're depressed, you might reach more quickly for that bottle of juice if your infant is crying and you just can't handle it anymore. You want to kind of quiet them in whatever way that you can. So I think when we think about childhood obesity as a family environmental issue, one factor that we found that was significant was you often don't think of maternal depression as a risk factor, but it can be.
And Dr. Wojcicki, what role does the built environment and environmental exposure experienced by the mother and father have on prenatal health, including childhood obesity risk?
Well, I think one of the things, it's less of an issue in San Francisco here, but if we think for sure globally and definitely nationally, a big risk factor clearly for childhood health in utero and postpartum is maternal and paternal smoking and secondhand smoke exposure. And there's been important studies indicating risk for a variety of adverse birth outcomes, but obesity as well. And I think we can also think just about air pollution and pollutants in the environment, in the air in terms of traffic exposures, what the child is breathing in. There's also been studies, clearly a lot with asthma, but also with obesity too. Other environmental exposures, including endocrine disruptors, I'm sure there's been lots of discussion already, but BPA, in terms of, again, additional studies showing those prenatal exposures are associated with subsequent obesity risk in kids.
And this is a question question for everyone. And if you could give one piece of advice to an expecting mother or couple about early action they can take to prevent childhood obesity that we haven't touched on already, what would it be?
Setting a good example. I guess I wouldn't be born yet. I guess for me it would be having everybody really eat well during pregnancy. I think that just sets up all the positive things. There's certainly no downside to doing that. And then I'll throw on my MSG thing again because there is an interesting study about MSG during pregnancy can actually damage the hypothalamus of the fetus, and they are more likely to then have issues with regulating appetite and things like that. So again, it goes back to the healthy eating during pregnancy and not eating junk food and not eating sugary foods because all of those things set the baby up for more challenges.
On some level, I think that's somewhat of a trick question in the sense that I don't know how many in the audience or here either have children of their own or work with kids, but I'm sure there's been a lot of discussion about the obesogenic environment that we're all exposed to. And those of us that do have, I know that myself, it's a daily struggle really to birthday parties, what's in the classroom, what's in the shopping malls, what your kids are seeing on TV, what they're seeing at their friends' houses. So I really think it's an institutional, it's a public health, it's a system-wide, it's a global problem. And I think from an individual level, it's very, very difficult. We need more community-wide, system-wide solutions to this.
I think I'm so glad you said that because one of the things I struggle with is really putting all the onus on mother to the health of the population is all due to those 9 months of pregnancy and it's up to you, and if there's any health problems in the community, it's because you didn't eat right. And it's a lot of, and especially with environmental toxins, there's only so much you can do. You cannot completely eliminate your exposure to those things, and nobody's going to be able to eat perfectly. One of the things I do want to say, though, is one of the things I focused on in my career is trying to prevent excessive weight gain during pregnancy, and that is modifiable. It is something we can help women achieve. Not every woman is going to be able to gain within the guidelines, even with her best efforts, but if we give women more support in terms of tracking their weight gain and helping them find strategies to reduce excessive weight gain during pregnancy, fewer women will gain excessively. And this will not only benefit her children, because many have done great research showing that women who gain above the Institute of Medicine guidelines during pregnancy, their children are more likely to be overweight later in life. So we have to do more to support women to have healthy weight gain. And one of the things my research has shown is that doctors are often not even talking to women at all during their pregnancy about weight gain. So there's a lot we can do just to get up to the basic standard of let's measure a woman's BMI at the first prenatal visit, let's counsel her. And one of the things I'm really interested in is using technology like smartphone apps to help women track their weight gain early in pregnancy. And it's not that we want women to get obsessive about their weight gain or get stressed about it, but just to have some monitoring of it going on earlier and be able to take some control over it. And we have stories all the time of women who say, I went to my doctor, I had already gained 50 pounds and I was not even 2/3 of the way through my pregnancy, and they said, don't worry, you're fine, you're healthy, and then I had a 9-pound baby and I had a C-section and I was really angry. And it was you and many other, you're not the only one. I have many colleagues who've told me this story, people who are highly educated, high-resource people who still didn't get support from their clinicians in terms of excessive weight gain. So I think one of the things I'm trying to do as an educator of clinicians is teach our residents to be more proactive in helping their patients.
Great, so we have some time for questions. Great.
Can you comment on, there was a study about a year ago that got some notoriety of claimed that the benefits of breastfeeding were overstated.
Well, they're actually, it's interesting, the benefits in terms of childhood obesity aren't crystal clear in the data. I will say that, and I'm not totally up to date on the latest data on all of this, but there was a meta-analysis that put together all the recent research. And I heard a talk from, I think Matt Gilman from Harvard gave a talk on this a couple years ago, looking at all the literature, looking at breastfeeding and childhood obesity, and it's not entirely clear-cut. There are a lot of association studies that show a benefit, there was a randomized trial in Belarus, I think, where they actually randomized communities, but it's a very different population from the population. Eastern Europe is not, they have very low obesity rates there to start with, at least at the time they did the study, and so a lot of people argued it's not generalizable, but they randomized people to like intensive breastfeeding education versus standard care, and they didn't see a benefit in terms of, I think they were actually, in terms of childhood obesity, but again, it's not the same population. I think another problem with studies here in the US is that very few women do the recommended exclusive breastfeeding for 6 months or even 12 months, which we think is probably better, not exclusive breastfeeding, but breastfeed for 12 months, 6 months of which are exclusive. Very few women do that, and in order to study the effect of that, we need a lot of women who really carry that out. A lot of the studies just looked at, did you breastfeed at all, and then look at obesity, and that's probably not the right question. So I think there is still some uncertainty. There is no uncertainty about that there are great health benefits to breastfeeding. So I think it's a no-brainer to recommend it and encourage it. But in terms of the effect on childhood obesity, I think we still need to learn more.
Yeah, I just want to follow up. I think you actually did a great summarization of some of the issues with all the clinical data out there, particularly the difficulty in doing trials. It's hard to randomize a mom that you breastfeed and you not. There's some clearly ethical issues. But there is, I always cite, there's a WHO meta-analysis where they synthesized a number of different studies, and what that found was a small but significant protective effect from breastfeeding for obesity. But again, that's been challenged, and there are different ways to look at breastfeeding data. So there is exclusive breastfeeding 4 to 6 weeks. There's the 6 months exclusive, and then there's breastfeeding to 12 months of age by the time complementary feeding clearly has started. So there's different ways to analyze the data, and also different time points in childhood to look for obesity as well. But again, I think that clear-cut, the immunological benefits from breastfeeding cannot be denied. So, but granted, your question is an important one, so thank you.
Hi, I'm a senior at UC Berkeley studying molecular cell biology with an emphasis in physiology, and I took physiology last semester. We learned about leptin, and my professor had talked about a study with mice, obese versus diabetic mice, and how in the obese mice, leptin was not produced to decrease appetite. And I'm wondering, I know that in humans there's a recessive mutation that does this same effect in humans, but it's very rare. And in other cases there is just insensitivity of leptin, and I'm wondering if you can expand upon that and talk about the possibility of using leptin as something that we can use to decrease obesity.
Yeah, thanks for your question. There's been many studies looking at the role of leptin as a hormonal mediator of appetite and leptin resistance in terms of obesity. I think your question is getting more at kind of therapeutic uses of leptin, and I'm not so sure about that. I think that whatever pharmaceutical company is able to come up with some type of drug to treat obesity, they're all looking for it, clearly. It's a gold mine in terms of population. So I really don't know in terms of what type of therapeutic developments there have been along those lines, but clinically, it's a hormonal marker that is always looked at in terms of relationship with satiety, appetite, and weight gain.
This is a question for Dr. Satlin. Is there research on the effect of a vaginal delivery for a mom that receives antibiotics for strep and the effect on the baby's flora?
No, I think this is a really, not that I'm aware of, I think this is a really understudied area, and I think we need to have more concern about I can't remember that, I think a huge percentage of pregnant women get antibiotics sometime during pregnancy, birth, process. I can't remember if it's a third or 40%, it's very high. And a lot of that is for group B strep prevention, and for those of you who may not be aware, pregnant women are all screened for this type of bacteria in the vagina that a lot of women carry asymptomatically, but if some babies who get it have a life-threatening infection, and so the solution has been for women who carry this bacteria to give them antibiotics during labor. But most of those babies wouldn't have gotten a severe infection. It's like pretty high number needed to treat, I don't know, which is the number we have to treat a lot of people to prevent one terrible, terrible outcome. So I think they need to do much more research into risk stratification. In other words, figure out which babies really are at risk to get group B strep bad infections. Maybe we can better characterize the bacteria that women are carrying. Maybe some strains are more virulent, rather than having this blanket approach where we expose so many women and their fetuses and babies to antibiotics that could potentially be affecting the gut flora.
That's a brilliant answer. I love that. Thank you. I had a question, just turning back to the breastfeeding debate. Looking at breastfeeding versus not breastfeeding, I think has its limitations, because within the breastfeeding segment, there's obviously a range of quality of breast milk depending on the mother's diet and other factors. So I was just wondering if there's any studies that looked at that.
I think those studies, there's very few. It's very difficult to do those types of studies. There's the dietary recall as an additional step, and then there's some studies that even want to go so far in terms of do the breast milk analysis, like what percentage fat, what are the components of the breast milk, the volume, the amount that the baby has been fed. So there are some, but very, very few, and to actually be able to then track those same infants and look for risk for obesity hasn't been done as far as I know.
One of the other interesting things, this is kind of a taboo subject, but I do think we need to talk about it, and I'm a huge proponent of breastfeeding. But one of the things that they are recognizing is that environmental toxins that women are exposed to are secreted in their breast milk. And to some degree, there's something, and I don't know the latest research on this, but there's some evidence, I think, that breastfed babies get higher exposure. Now, that's almost certainly outweighed by all the benefits of breastfeeding, but that doesn't mean we shouldn't do more as a population to reduce women's exposures to potentially toxic chemicals in the environment. And it's really fascinating. There's research that shows that whether it's I think it's the first child that gets the highest load of toxins in the breast milk, because your body mobilizes fat that may contain toxins that have been stored there long term. And then with the next baby, you've sort of relieved yourself of some of that lifetime load. So the first baby takes the biggest hit of environmental chemicals. So it's one of these areas that environmental scientists are really touchy about, because we want to know what's in the breast milk, but we don't want to discourage women, scare women away from breastfeeding, because it's still very clear to all experts that breastfeeding is still, the benefits outweigh these risks. But I think it's a really important thing to recognize, so that we continue to do things to reduce women's exposure.
Right? I mean, there is a study, there's a longitudinal study, actually SFGH, looking at environmental toxins in breast milk. In particular, I don't know if they're looking at infant outcomes as well, or just trying to quantify.
It's an interesting question, because they could screen women for toxins at some point, but yeah, it is tough, because everyone's going to have some, and you don't want to scare everybody against it. So unless you screen for super high levels, maybe, yeah, it's a tough one.
I have a question. Now that we're getting into things like looking at fecal transplants, is there any effort to try to look at the flora that babies miss by having C-sections, and to try to expose them to that flora?
I think there is, actually. I mean, you might know more about the actual research going on, but I know that they're looking a lot at, at autism and stuff, they do, and gut people, they look a lot at the different types of microbiome and what is going on with it. But maybe somebody else knows more about some of the specifics about that.
I haven't seen any trials looking at, as a again, therapeutic for kind of treating obesity per se. I've seen more, there's been trials looking at probiotics, introduction of probiotics for like development of asthma in kids or other or allergic conditions, inflammatory conditions. But there could be something with obesity. I haven't seen any trials. I've seen studies to look at, is the gut flora different in kids who are obese versus not? And clearly there are important differences. There was a case that came out, I don't know if some of you saw this, in the news a few weeks or a month ago, where there was a adult who had been treated for C. difficile transplant, got a fecal transplant from her child who was overweight, and the recipient of that fecal transplant went on to actually develop I don't know whether she became overweight or obese, but she had huge weight gain, much more than would be expected. So that was actually quite interesting, just that solitary case study. But I haven't seen any other trial or anything like that.
And that's true for mice. They do that in mice. They take the microbiome from one mouse and give it to another, and the obese mice, the non-obese one will turn obese if they get the flora from that. They do a lot of studies on that.
There definitely have not been fecal transplant studies in babies now, but what I've always thought as soon as I heard about this is I thought, why don't we just take mom's underwear and put it on the baby's face? Smear it all over the baby. But seriously, how is that any different from going through the birth canal, right? It's so interesting historically because I heard a professor once say, it sounds crazy, but this is like a life or death thing. I mean, it's really important. And I heard somebody say once, evolutionary-wise, it's not a coincidence that the anus and the vagina are right next to each other. We could have the birth canal come out of the neck, or we could have it come out of the back, but it's right next to the gut flora. There is a reason for that evolutionary, and so that needs to happen. But I may be imagining this, but I think I saw a study that's going on in Europe somewhere where they are basically doing, they're swabbing the baby with mom's bacteria, with just like a cotton swab, right? It could be something as simple as that. Because if you think about what happens in the birth process, it's just smeared all over you. You don't have to do a transplant or ingest a capsule. It's just smeared all over you. So maybe I'm thinking, why don't we just try something, moms? And I just want to say, we're coming from a history where, when my mother gave birth in the hospital in the 60s, before she could breastfeed, and breastfeeding wasn't that encouraged back then, they would try to sterilate. She had to swab her nipples with alcohol because her bacteria is going to contaminate the baby. And now it's so backwards from now how we understand how mom's flora is good for baby. And when I was a medical student in the 90s, when women were having a normal spontaneous vaginal birth, we used to swab the vagina with betadine with antiseptic stuff, and if there was, any poop around there, we'd swab and sterilize, and not realizing that that's what the baby needs. The baby needs to be exposed to mom's, gut flora. So I think we're having to be comfortable with saying that is actually good for baby because hospitals are so used to keeping everything sterile. So it may be a while before American hospitals are ready to try something like that.
I just was wondering if there's any research being done, or I think I've heard about research being done around the foods that a woman eats when she's pregnant can affect the palate, the taste palate of the baby, and I've heard that, and I'm curious about the research and what they're finding about that.
That is true. They have done research already on that. I'm sure there's more going on, but they are looking at not only it for mom that's nursing, but for a mom that's also pregnant. The baby is able to sense different smells, different flavors, different something in the amniotic fluid, or I don't exactly know all the mechanisms, but they have found that in pregnancy, that the more diverse the mother's diet is during pregnancy, the more likely the baby will be a more diverse, hearty eater.
Hi, I'm wondering about risk factors for gestational diabetes mellitus. Is it weight gain per se that's the largest risk factor, or is it something else about the diet, the macronutrient balance, or micronutrients? Is it really weight that matters the most?
Yeah, there are a number of risk factors for gestational diabetes, and they really mirror the demographic factors just mirror exactly type 2 diabetes. So, being Asian or Latina, but weight, mother's pre-pregnancy weight is probably the number one risk factor for gestational diabetes. The studies are a little bit conflicting, but there are a couple good studies that show that the amount of weight women gain early in pregnancy predicts her risk also somewhat of getting gestational diabetes. So we may be able to modify women's risk factor by having them really restrict their weight gain in the first half of pregnancy. But that's still controversial. Fascinatingly, we did a study at UCSF that showed that the race and ethnicity of the father predicted whether the mother got gestational diabetes. So the fetus is driving this as well, because the placenta comes apart from the father, the DNA, and so if the mother's Caucasian, which is a lower risk group, and her partner is, Asian or Latino, she has a higher risk of GDM, which will then affect the baby's health as well.
Great. Well, that concludes our last panel. Thank you all. Oh.
Sorry. I just wanted to say one last thing. I really, really appreciated Dr. Sotland's comment on, if there's one thing you remember from this conference, there's an evolutionary reason for why the anus and the vagina are so close to each other. I think that really summarizes